Good afternoon, everyone. The title of my talk tonight is Diagonal Ascent to Hit Oxygen Targets. I'm Emily Aventura, Pulmonary Critical Care Specialist. At the end of my talk, you should be able to recognize the clinical impact of hypoxia, more importantly, describe the effects of hyperoxia, and discuss about appropriate targets in hypoxemic respiratory failure. I will not go into the much detail of the effects of hypoxia. It is well known that failure of aerobic respiration because of hypoxemia leads to obvious and immediate catastrophic consequences, culminating with cardiac arrest. Therefore, historically, the predominant approach has been to ensure avoidance of hypoxemia with liberal use of supplemental oxygen and to tolerate hyperoxia. The concept of oxygen toxicity was originally described in the late 19th century. However, it took a century before the effects of hyperoxia were better understood. We have begun to more fully appreciate the negative consequences of hyperoxia, which may be delayed and insidious, such as reduced microvascular circulation, vasospasm, acute lung injury, and systemic inflammation. Intuitively, one might expect that when breathing high levels of oxygen, minute ventilation will fall due to inhibition of peripheral chemoreceptors. However, after an apparent transient decrease in ventilation within the first 1 to 2 minutes of hyperoxic breathing, a paradoxical increase in the respiratory response increases minute ventilation, rising beyond pre-exposure levels within 5 minutes in a dose-dependent manner. The best explanation for this phenomenon points to the Haldane Effect, which weakens the affinity of carbon dioxide for hemoglobin when high levels of oxygen completely saturates hemoglobin, thereby acidifying the cerebral spinal fluid and necessitating CO2 removal via hyperventilation. When the exposure is prolonged for 8 hours to as long as 5 days, ventilation progressively decreases over the duration of the exposure. It was also suggested that the stimulus that triggers the initial hyperventilatory response is not sustained due to a decrease in cerebral blood flow and or a reduction in the efficiency of carbon dioxide carriage by the blood. Finally, oxygen toxicity could have a negative impact on the physiologic response. However, this would depend on the level of hyperoxia. The use of hyperoxia in clinical conditions of hypoxemia, most notably in our COPD patients, depresses the respiratory drive, putting the patient at risk of respiratory depression, hypercarbia, and CO2 narcosis. Besides depressing the ventilation, hyperoxia can directly affect gas exchanges by promoting the collapse of metastable alveoli. Inhaled O2 replaces the other gases in the alveoli and being quickly absorbed into the blood, decreasing the residual volume and prevents the expansion of the alveoli, the so-called absorption atelectasis. Furthermore, unless remodeling has occurred, hyperoxia can reverse the hypoxia-driven vasoconstriction in hypoventilated alveoli. This means that perfusion decreases in otherwise poorly ventilated lung units, thus increasing the ventilation perfusion unevenness and ultimately worsening gas exchange. As a consequence, the dead space ventilation increases from 77 to 82% in some studies. Unlike in the lung, where oxygen causes vasodilation, hyperoxia-induced vasoconstriction has been observed in various vascular beds, including the heart, skeletal muscle, and the brain, and can reach levels 30% lower. Increases in systemic vascular resistance leads to an increase in blood pressure and afterload. thereby reducing stroke volume and cardiac output, which ultimately leads to a decrease in coronary sinus blood flow. The evidence overwhelmingly demonstrates that while breathing hyperoxic gas mixtures, coronary blood flow measured via catheterization is reduced compared with normal air. Well, for obvious reasons, the individuals participating in such studies often present with cardiac diseases such as coronary artery disease and congestive heart failure. That's why they end up undergoing cardiac catheterization. But it is noteworthy that although all of these studies include cardiac patients, Gans et al. In one of their studies also compared coronary blood flow responses to hyperoxia in healthy individuals, and the results followed a similar trend. This review from the British Medical Journal of 8 randomized controlled trials tells us that while treating acute myocardial infarction with oxygen makes sense from a physiologic standpoint, no studies have convincingly demonstrated that oxygen therapy improves outcome in acute myocardial infarction. In addition, recent data suggests that this practice may even be harmful. The initial mnemonic, the treatment mnemonic MONA, I'm sure a lot of you are familiar with, the MONA for ACS has fallen out of favor. O being oxygen, MONA, so morphine, oxygen, nitroglycerin, and aspirin. One of the main mechanisms limiting the potential benefit of oxygen therapy in cardiac patients relates to the negative hemodynamic changes associated with hyperoxia due to the reduction in nitric oxide bioavailability. The different oxygen targets of the 3 different studies led to the recommendation of the European STEMI, European Society of Cardiology STEMI guidelines in 2017 to use oxygen supplementation only if O2 saturation is less than 90%. So if they're not hypoxic coming in the ED, you don't necessarily have to put oxygen on them. But how much oxygen is too much? With oxygen being both essential and toxic, it is rational to hypothesize that the dose of oxygen administration is key to its effective use as a therapeutic. The logical goal is to administer enough oxygen to maintain aerobic respiration, but not so much that the body is overwhelmed with reactive oxygen species. Replicate retrospective analysis were conducted of 2 electronic medical record databases, the EICU Collaborative Research Database and the Medical Information Mart for Intensive Care database. The analysis identified over 26,000 and over 8,000 patients respectively. The optimal oxygen saturation was 94 to 98% in both databases. The percentage of time were within the optimal range of O2 sat was associated with decreased hospital mortality. The authors found a U-shaped association between the SpO2 achieved and mortality, with SpO2 on both the lower end, less than 94% in this case, and higher end, greater than 98% of what is typically achieved in clinical practice, between 94 and 98. Beyond these values were associated with higher mortality than if they were in the mid-range, between 94 and 98%. While these results are vulnerable to confounding, obviously, and do not definitely identify an SpO2 range for clinicians to target in practice, the findings are useful. Namely, this study reinforces the concept that the highest levels of oxygenation are associated with a measurable increase in mortality in observational data. And avoidance of hyperoxemia may be an important component to maximizing survival in patients who are critically ill. Furthermore, this study implies that even using oxygen to maintain high SpO2 levels, example 99%, could be detrimental in practice. Girardis randomized 434 adults admitted to a single medical surgical ICU to a conservative oxygen target, meaning between 94 to 98%, versus the conventional oxygen target of 97 to 100%, while allowing PaO2 values up to 150 millimeters mercury. They found a surprisingly large difference in ICU mortality, 11.6% in the conservative 94 to 98% range versus 20% in the conventional group of 97 to 100% target. So 11% versus 20%. In the ICOS Trial, the Australian and New Zealand Intensive Care Society Clinical Trials Group conducted a multi-center trial in which they randomized 1,000 adults on mechanical ventilation to a conservative oxygen target of 91 to 96% versus usual care, the oxygen strategy determined by the physician with no input from the study protocol other than avoidance of SpO2 of less than 91%, they found no difference in ventilator-free days or survival between randomized groups in the full study population, but found significant heterogeneity of treatment effect with conservative oxygen therapy favored in patients with hypoxic ischemic encephalopathy. Derek Chu and colleagues analyzed 25 randomized trials in the Improving Oxygen Therapy in Acute Illness, or the IOTA systemic review and meta-analysis to define the efficacy and safety of liberal versus conservative oxygen therapy in acutely ill adults. The authors concluded that supplemental oxygen might become unfavorable above peripheral O2 saturation range of 94 to 96% because the risk of death increases in a dose-dependent manner. Their findings simply imply that when too much oxygen is administered in acute illness, it can exacerbate the patient's health problems. In the Handling Oxygenation Trial, or the HOT ICU trial, investigators, it was an investigator-initiated multi-center randomized control trial across 35 ICUs from European ICUs from June 2017 to August 2020. It is a 1:1 randomization of almost 3,000 patients to receive oxygen therapy with either low with the PaO2 of 60 and high with a PaO2 of 90. The trial showed no difference in 90-day mortality in the lower oxygenation target compared to the higher oxygenation target in critically ill patients with acute hypoxemic respiratory failure. The results of this trial are not all that surprising, as the two groups were essentially very similar. The low oxygen target group had a mean O2 saturation of 93% compared to 96% in the higher oxygen target group. Investigators in France randomized patients with acute respiratory distress syndrome to either a target partial pressure of oxygen of 55 to 70 millimeters mercury, the conservative group, which is 88 to 92%, which is actually the target for our ARDS-NET trial. Or comparing it to a PaO2 of 90 to 105, which they call the liberal group, which targets a saturation of over 96%. Although higher mortality in the conservative group did not reach statistical significance at 28 days, mortality at 3 months was significantly higher in the conservative group. However, at the conservative titration goal, some patients likely had episodes of severe hypoxemia. This might be the reason for the signal for harm, even though previous studies have suggested that lower oxygen targets are safe. Avoiding an oxygen saturation of 100% still seems prudent, but titrating down to a saturation of 90% or lower might put patients, at least those with ARDS, at risk. A target in the mid-90s seems reasonable for patients who receive mechanical ventilation. Based on Barcroft's original classification, there are 4 types of hypoxia. Hypoxic hypoxia, wherein oxygen of the arterial blood is low. Anemic hypoxia, wherein amount of hemoglobin to carry oxygen is low. Stagnant or ischemic hypoxia, where blood flow to the tissue is low in the setting of hypotension. And histotoxic hypoxia, wherein tissue cannot utilize oxygen. So to define a patient's oxygenation status based solely on the basis of SpO2 is too simplistic, given that there are several etiologies of hypoxia. In addition to SpO2 as a surrogate marker of tissue oxygenation, tissue oxygen delivery and consumption should be assessed to guide supplemental oxygen administration to the individual acutely ill patient. As surrogate parameters of these variables, blood lactate concentration, central venous to arterial CO2 difference, and central venous or mixed venous oxygen saturation could also be used. I will not be discussing these on this session, as it is a whole different talk altogether. And although avoiding hyperoxia seems to make sense, trying to titrate oxygen this tightly does not confer a benefit. In addition, the number of blood gases needed to do so seems excessive and potentially harmful. For most critical ill patients, having PaO2 in the range of 60 to 90 millimeters mercury or oxygen saturation in the low to mid-90s is appropriate. While we await for the results of larger trials like the MEGA-ROX trial or the HOT COVID trial, which is an amendment to the HOT ICU trial, targeting an SpO2 of 92 to 96 or a PaO2 of 60 to 90 seems to be the ideal target for now. And I leave you with this. Oxygen supplementation should be used judiciously and with the primary goal to relieve hypoxemia without inducing hyperoxia. Thank you and stay safe, everyone.